Welcome to Session 1 of the PneuBack Program Level 1. In this session, we will be examining patient intake and evaluation. As a result, we will be going through examination and orthopedic testing, along with history review, X-ray evaluation, and radiographic anatomy basics. Before we begin, it is important that you have gone through the manual and read through the material, and we would recommend that you have the manual available as we go through this webinar. During patient evaluation, it is important for us to essentially figure out what we need to figure out on the patient to see if we are able to adequately help this patient with the problem that they are presenting with. As a result, when we go through the webinar, I'm going to talk about indicators and contraindicators for the usage of the Level 1 program. Indications for usage of Level 1 is that the PneuBack program was primarily designed for patients with acute and chronic lower back pain, primarily the pain that comes as a result of a disc herniation, as well as radicular symptoms, or pain that results from sprain strains and spondylolisthesis and spinal instabilities. The contraindications are important in the program because we utilize a lot of specialized equipment, and some of the equipment may actually exacerbate a problem if not used correctly. The two main pieces of equipment that we are talking about is primarily one traction and the other one is vibration. When we go into looking at the contraindications, we will start with talking about the unweighting system. The unweighting system is a very specialized unit in that it utilizes a special vest that anchors underneath the rib cage and around the armpit and provides traction from that perspective on. As a result, because the unweighting unit works in such a way that the harness will compress in on the rib cage as it is being pulled upwards, we need to be very aware that no patient with respiratory conditions that are exacerbated with pressure on the rib cage is put on an unweighting system. This is important because the rib cage essentially expands as we take a deep breath in, creating a negative pressure to open the lungs themselves. Patients with spinal tumors are also another special category that are contraindicated for the unweighting system, in that spinal tumors can actually rest within the vertebral column itself and not cause any problems until traction force is placed and compression is placed on the spine itself. So as a result, we need to be very careful in the unweighting system that these two categories of patients are avoided. When we look at the vibration components, whether it's the VibroTrack table or utilizing the ProVibe, it is important that we keep in mind that there are certain categories of patients that we want to avoid utilizing the vibration platform for. In the first category, these are patients that we recommend that you do not place the following patients on. These are patients with unhealed fractures, with active cancers or tumors, with abdominal aortic aneurysms, with unhealed surgeries, with pacemakers within 12 months, as well as patients who are pregnant. The reason why we try to avoid patients with unhealed fractures and unhealed surgeries is that the vibration component may actually prevent these from healing properly or cause more damage if not properly used. Furthermore, with active cancers, tumors, and aneurysms, we need to be extremely careful because we know that the vibration has a component that actually increases the amount of vascular flow, meaning arterial flow out to the periphery and venous return to the heart and lungs, as well as lymphatic return. The next category of contraindications for patients with vibration, in this category we recommend using high caution with the following patients. This does not mean that they cannot be placed on the equipment. What it does mean is that 1, no high amplitude or frequency exceeding 30 Hertz is recommended, and 2, the patient needs to be monitored continuously while they are on the equipment. This group of patients includes people with a history of deep vein thrombosis, severe cardiovascular compromises, total joint replacements, metal pins, plates, or implants within the past 12 months, patients with severe migraines, epilepsies, or seizures, and patients with lumbar discs while weight-bearing, that is lumbar disc pain while weight-bearing. In the case of the patient with the lumbar disc, we highly recommend that you keep the patient recumbent as the non-weight bearing tends to alleviate any pain or discomfort. Now, when we are looking at the patients where we recommend the use of high caution, a very good rule of thumb is to ask the patient continuously whether they feel pain or discomfort. In fact, this is highly recommended for any patient and every patient that you place on any of our machine, as pain is not an indicator of proper usage. In fact, the patient should actually report no pain or discomfort when they're on the machine. Remember, when we're dealing with patients where we recommend the use of high caution, we never use high amplitude, especially on the table, and we never exceed 30 hertz of frequency. The final category for patients under contraindications with vibration is the use caution category. In this case, the patients should have no problems with utilizing the equipment. However, again, we recommend that continual monitoring of the patient is done throughout the treatment. In this category, we're looking at patients with hypertension, with non-recent implants, and these are greater than 12 months, with loose bone chips or fragments, with severe diabetes, recently placed intrauterine devices, circulatory disorders that may increase or decrease blood flow, or neuropathies. The concern with these patients then is that with diabetes and neuropathies is that we want to ensure that there is no friction or damage to the skin or joints that the patient cannot feel. Circulatory disorders such as Raynaud's disease need to be monitored again, as we know that there is a vascular component that occurs when the vibration therapy is being done. The first step to having a good evaluation of a patient must start with the history and chief complaint. Now, I understand that many of you who are listening to this webinar are seasoned and experienced clinicians, and what we are recommending is just simply a method of evaluating patients that will help us to, in the end, come up with an appropriate and proper diagnosis. The history and the chief complaint are extremely important to what we do because it primarily is the starting point of deciding how we will utilize the orthopedic test, as well as what we would look for when evaluating x-rays. It is important then for history and chief complaint that we review and understand the injury. This includes primarily the mechanism of injury as well as the pain, where the pain is, how the pain is, what the patient feels. At this point in time, we would also include such things as the pain is sharp, the pain burns, as well as our usual visual analog pain scale readings as to what the patient is feeling. We would also at this point look for anything that can exacerbate the pain. So for example, if we're talking to a patient who tells us that standing for long periods causes more pain into their lower back, that is significantly different from a patient who tells us that laying down on their back significantly increases the lower back pain. The other thing that we need to be aware of is to listen to the patient's entire history. Oftentimes we may have patients who have come in from other practitioners who have previously made a diagnosis, and what they will bring into us is the diagnosis from the other practitioner. So one of the very common ones that we see is that my medical doctor sent me in and told me that I have lower back sprain/strain. That is a good indicator of where the problem is for the patient. However, we need to still do our own due diligence in going through the chief complaint history and evaluation process to ensure that it truly is a sprain or a strain that the patient is dealing with. Knowing where and how allows us to understand what may be injured. So again, this is very important for us to understand that oftentimes patients may feel pain in a certain area or a specific area. We need to understand where that is, but we also need to see where else they feel pain. Oftentimes the area of pain is not the area of injury, but can also be the area of compensation, and we need to be aware of that. Look for motions, again, that enable you to replicate the pain. So, for example, when we're talking about our patient who then could not stand for periods of time without feeling pain, one of the things then that we would try to do is see if during the interview we can do certain things that will initiate the pain. So for example, if going upstairs can cause them discomfort to do it, we will try to see if we can mildly replicate those pain or that area of pain. The other thing we would also look for are areas that do not cause pain. If we know that something does not cause pain, very likely we will approach that perspective when utilizing the equipment and going through the treatment protocol. We need to be aware of recent surgeries or possible complications. Again, this goes hand in hand with the contraindications that we started with. As we know that many patients have more than one problem, it is our responsibility to know each and every one of those prior to starting. We need to realize what we can and cannot do and then determine if we can help the patient. And this is really an important factor of taking the history and chief complaint. If this is a problem that we can help the patient with, then we can tell the patient with certainty that we can help you. However, if not, we do need to know the limitations of what we are doing so as to be able to provide the patient with the best care possible. We want to collect as much information as we need to make a good, solid diagnosis. And the history essentially is what drives the orthopedic test as well as the radiographic review. So it tells us what we are looking for. So this history and the chief complaint is essentially the thing that will drive us and help us to figure out where we need to go, which orthopedic tests we're going for, and what radiographic things we're going to be examining on the x-ray itself. One of the things that we've always been told when we were going through class is that history and chief complaint, essentially as a result of that, anywhere from 70 to 80% of the diagnosis can be made as a result of these things. The orthopedic examination is primarily designed as a standardized testing situation that allows us to evaluate the systems in a direct and ordered fashion. When we do the orthopedic examinations, there are specific things that we will be looking for, and being familiar with what the positive and negative findings indicate will help us to really hone in on what we heard about in the mechanism of injury or their initial chief complaint. So for example, if we meet a patient who tells us that they were riding in a water or jet ski and they got thrown off and landed on their head with their head bent towards the right side, one of the things then that we would look for is that we know that doing something like foraminal compression test to the left side or to the right side can indicate with pain that there may be some involvement of the IVF, including a possible disc injury. We can also look for the same patient utilizing something like the shoulder depressor test, where we would look for radiculopathy or pain. So this will help us to distinguish between whether there's an arm pain or a radiculopathy versus, say, a localized cervical pathology like a sprain or a strain. When we are doing the orthopedic examination, based off of our original chief complaint then, we will be looking specifically for things like sprains and strains, anything that has a disc involvement, pathology, or even the dermatomal pattern that will help us to isolate the area where the nerve root may be irritated or damaged. We'll look for vascular and neurologic involvement, so that includes such things as swelling and inflammation, as well as loss of sensory and sensations, pins and needles, those types of things. We'll also look for radiculopathies, as well as fractures, instabilities, and impingements. The orthopedic examination then is primarily guided by the chief complaint that the patient comes in for. However, we also do utilize these orthopedic tests to rule out certain pathologies. So if a patient has certain problems into the lower back, it is good to be able to distinguish whether it's an SI pain, an SI lesion, whether it is a sciatic type problem, a true sciatic type issue, whether it comes from the lower back or whatever else that the person may be presenting with. The next step is to, after we've done the initial examination or chief complaint and gone through the evaluation utilizing the orthopedic tests, the radiographic evaluation is really the next step. One of the very important things that we need to keep in mind when we're reading radiographs is that radiographic findings in the absence of symptomology is considered to be an incidental finding. So for example, if we go and we read an MRI and we find that a patient has a disc herniation on the MRI, but yet they have absolutely no complaints of pain in the affected area, for example, their lower back, then we tend to leave that disc herniation alone. It is asymptomatic and not something that we want to go through and start to play around with, because there is a good chance that we could irritate the area. Now, going through radiographic evaluations, we provide you with a mild introduction to it, but the best recommendation that we can make to you or to any clinician is that you go through an actual radiographic anatomy class. So the class will actually teach you how to appropriately read x-rays, to help you to appropriately read and evaluate MRIs. Now, when we're reading these things, they're actually the in-depth reading of x-rays and MRIs is beyond, again, the scope of this webinar and this class. However, there are certain things that we would recommend that you pay attention to as you go through looking at x-rays and MRIs in your own clinic. The first thing is that when reading radiographs, whether an MRI or an x-ray, you need to note not only the things that you see that may look funny, but more importantly, the things that are missing. So one of the things that we utilize radiographs to look for then are things like cancers or tumors, and oftentimes these are lytic lesions, meaning that they will erode away the bone, or they will remove things like spinous processes or transverse processes that might be missing, or pedicles. So it's important then that we catch the things that are missing just as much as the things that are there. The other thing to remember when we're evaluating radiographs is that there are differences between MRIs and X-rays. Now, as a quick basic review, if we imagine that we have a loaf of bread and there's a key that is baked into the bread, if we take an X-ray, if we say shoot an X-ray from the front to the backwards part of the loaf of bread, you'll see the key isolated in the middle, because the X-ray actually shoots straight through that bread and into the film behind it. If we take the bread and we rotate it 90 degrees, so we're looking at it from the side, we get a second view, and it will again show us where that key is in relation to the bread. Again, the X-rays will pass straight through the entire loaf of bread until it gets exposed on the other side with the film. An MRI is slightly different. MRIs are not like X-rays in that MRIs do not pass entirely through that loaf of bread. You can imagine an MRI image now then is that if you take that loaf of bread and you cut it into slices, as you cut it into slices, you can only see the front half of the slice of bread. As you remove that slice, you only see the front half of the one behind it, and so on. So an MRI, really what it does is that it gives us cross sections that we have to, in our mind, put the pieces together to see what the actual image looks like. There's another big difference between an MRI and an X-ray. X-rays are primarily utilized to look for bony structures, so things like bones, calcifications within tissues. You can kind of see soft tissue in certain cases. You can also see things like gas and air bubbles as they appear black on an X-ray. In general, however, X-rays are not sufficient when evaluating discs themselves, especially if you're looking for a rupture of a disc. Now, you can make an assumption on a degeneration of a disc with an X-ray. However, you cannot clearly see the actual disc itself. An MRI is different. MRIs are weighted differently in that there's a T1, there's a T2, and there's a spec version of the MRI. In that what the weighting does then is that it will excite certain tissues within the body. A T2 is for water, T1 will do fat or adipose tissue. And you need to be aware of that, because depending on what images you're looking at, different things will appear bright white on an MRI. The final thing to remember between an MRI and an X-ray then is the position of the patient. Most X-rays can be taken either in a recumbent or a standing or seated position. Most MRIs are primarily taken in a recumbent position. However, the newer MRIs allow for sitting as well as standing. X-rays, we need to be very careful. There are typically markers that are placed on the X-ray that will tell us where the left and the right side are, and the markers usually have a little BB on the inside that tell us what up and down is. So if you're looking at an X-ray, you need to especially be aware of, is this a weight-bearing X-ray? Is this a seated X-ray? Is this a recumbent X-ray? Because those types of things become important, especially if you're looking at the side views and you're trying to determine things like central central gravitational lines, lordosis, kyphosis, the curvatures within the spine. So be aware that the films can be taken in different positions as well. Okay, remember when we're looking at MRIs, particularly disc herniations, but this also applies to a lot of other things, especially things that can cause pain or discomfort, but particularly MRIs. Without symptoms, they are considered to be incidental findings for a disc herniation. Statistic actually shows us that out of 100 patients, about 70-something% of those patients will present on an MRI, if we randomly draw these patients, with having a visible, true disc herniation. However, they will feel absolutely no pain. And as a result of this, we need to make sure then that if the patient has no symptoms of a disc herniation, despite it being visible, we got to leave that alone, because there is a good chance you could irritate that area and cause a problem. Okay. Finally, the thing that we recommend when it comes to radiographic evaluations is that if you can, we highly recommend that our clinicians evaluate the actual image themselves versus just reading a radiology report. Radiology reports are excellent in that they can help us to know where the problems are. They are essentially experienced set of eyes. The radiologists are able to look for gross pathologies, but that's primarily what a radiologist will look for, a gross pathology. They will ensure that there are not things like cancers, tumors, those types of problems. However, most radiologists do not tend to report on things like ligamentous instabilities, central gravitational lines, some of those other things that will become important to us, especially as we set up to do some of the work that the equipment is set out to do. In radiographic evaluations, there are the ABCs of evaluation, and these are primarily just a simple rule of thumb that you can run through should you have a chance to look at an MRI or an X-ray as it passes through your clinic. The A stands for alignment. Now, remember, when we're looking at alignment, this is primarily not just the curvatures of the spine. It's not just the way that the bones are next to one another. When we're looking at alignment, there's a lot of different things that we look at. In the manual, we talk about drawing a central line. We talk about measuring things like the L5 mammillary to sacral base. We look at things like the anterior vertebral body lines, the posterior vertebral body lines, spinal laminar junctures. We look for stair stepping within the posterior region of the vertebra. All of these things are designed to help us to know where the cause or the root cause of the problems are. So for example, if we draw the lines and we can see the stair stepping as we outlined in the manual, that is a very good indicator that this patient has something like a spinal instability, which most commonly they will describe as a continuous aching pain that does not go away. They'll kind of need to shuffle and move around. And you can typically see these patients as they go through meetings or go to church. They can't really sit still on a hard pew. It bothers them after a while. The important thing when we're talking about alignment then is to realize that most radiologists do not look for these things biomechanically. However, they are very significant in what we would do. So in one of the pages when we look through the manual, I talk about the lumbar gravity or Ferguson's line. In Ferguson's line, if this is a patient who is standing up and we see that the Ferguson's line is actually off of where it should be, that tells us that the patient may either have an anterior, a hypolordosis, or a posterior or a hyperlordosis. That affects the way that we will set up the patient. So a patient who is hyperlordotic, we would definitely want to make sure that there's actually a wedge underneath the sacrum when we go over to the vibrotract table. So we want to catch these types of issues on an X-ray, as they're good indicators to us as to what we need to do and how we do some of the work that we do. The B portion of the ABCs then is bone. We need to be aware of things like fractures and breaks, as well again as the apposition where the one joint is next to the other, do they line up properly, and finally the shape of the bone. So there are certain variations that again normal radiographic anatomy will tell us that the shape of the vertebra and the neck and the thoracic and lumbar spine are all slightly different. They get larger as we go down. Some of them are more cube shaped, others are more oblong. and rectangular shape. So knowing what regular radiographic anatomy looks like becomes very important. Now, there are certain points as well then that we need to know what else is normal. For example, we're looking for a fracture, then as we're looking at a young child, the area where the epiphysis, where the growth plates are, oftentimes can appear to look like a fracture point. However, if you look at them on both sides, they tend to be symmetrical. It's not unusual to see a dark line there because that is where the growth plate is. However, we're not aware of what normal radiographic anatomy looks like. We may misinterpret some of those films. The last one that is very common that we need to look out for is actually at the odontoid process. So if we're looking at the posterior arch of the CO, then it can oftentimes appear like a fracture or crack at the base of the odontoid process. And it's important for us to catch that, because if there were true fracture, then we wouldn't even try to treat the patient. With a true fracture of the odontoid process, it is an immediate referral in for surgery, and they won't even wait on a patient with a true odontoid process crack. However, there are things that we can do that will help us to look for that. For example, patient comes in with a severe traumatic injury, car accident, they fell off a cliff, something like that. That is a mechanism of injury that could point towards a fracture of the odontoid process. So we need to be aware then when we're looking at bone that what is normal, what is not normal. There can be modeling processes. There can be osteopenia that can actually be seen off of an X-ray. So you know, we want to be careful as to what we can see and what we cannot see, but we need to look at all those structures. Cartilage themselves, remember, off of X-rays in general, you cannot see cartilage. However, what you can see are blank open spaces, particularly between the vertebral bodies, and you can look for wedging where instead of being a nice flat rectangular shape, it's actually wedged where one side becomes higher than the other. This is an abnormal type presentation. So we want to be able to catch those things and be aware of those things. The last thing in the ABCs is S, which is the soft tissues. Then we want to look for things like calcifications, abnormalities, even things like the abdominal aortas. If we look at a lateral lumbar film on patients with abdominal aorta type issues, the abdominal aortas actually run anterior to the spine itself, and you can actually see calcification on the walls, and it'll look like a large balloon with chunks of calcification. If we see those types of things, we want to be very careful with those patients, following our contraindication list or the requirement for caution then, that these patients, we want to make sure you don't increase things like intra-abdominal pressure. So for example, making sure they don't bear down too hard or do real heavy sit-ups. Those types of things can cause a rupture of the abdominal aorta. So the last thing that we want to make sure of, especially when we're evaluating X-rays then, is that we need to remember the normal exceptions in anatomy, and these include things such as the coupling effect. The coupling effect is really defined because of the shape of the posterior segments of the vertebral body and the way they kind of ride one on top of the other. As we take a patient's spine and we bend them to one side, whether you're looking at the neck, the thoracic, or the lumbar spine, there's actually a rotational component in there. And as outlined in our manual, if you're looking at the cervical spine and the patient bends, say, to one side, the spinous process will actually rotate towards the concave side, and that's a normal coupling effect. If we're looking at a patient that's leaning to the right side, then in the thoracic spine, normal coupling effect says then that the spinous process actually turns to the convex side, and in the lumbar spine, the spinous process goes to the concave side. Now, this is important to know, because when we're starting then to look at patients with lateral curve problems such as scoliosis, we need to be able to determine what is normal and what is abnormal. And knowing something like the coupling effect helps us to kind of put that together. That brings us to our last point, which really is putting everything together. So if you think about the process that we have gone through so far, in terms of our patient evaluation, we always will start then with the history from the patient, then we move over to the orthopedic testing and examination, and we always end up with a radiographic review if possible. Now, one of the things then that we want to make sure is that, remember, the history is the thing that drives what orthopedic tests we're doing. It also drives what we'll be looking for in our radiographs specifically, because we want to double check that area of pain where the person is feeling their discomfort. Now, as we get all these three pieces together with the history, the evaluation, and the review of the radiographs, then we start to form our diagnosis here. And there's a few questions that we really want to ask ourselves as we go through the diagnosis. One is, does this diagnosis make sense? Meaning, does the mechanism of injury explain what this patient is feeling? So if a patient says then that I am feeling extremely bad lower back pain, and their mechanism of injury is that they fell out of a chair and onto the floor, and they hit the floor really hard, one of the things then that mechanism of injury would tell us then is that, yes, it is possible that the pain that they're feeling in their lower back could be a result of, say, something like a compression fracture or some other sort of injury into the lower back, and that's why they feel the pain. However, if a patient says that I have pain in my lower back, but I banged my head, then directly we need to say, okay, does this make sense? It possibly could make sense, because if they bang their head and now they're bearing weight differently and loading the spine differently, then they could have pain in their lower back. But then again, if that is not the case, then the mechanism of injury does not match the pain, and we need to look for something else. The next question then that we need to ask about then is, does the pain pattern match my diagnosis? And this is really very important. So if the patient comes in and they have a diagnosis that we've come up with that says that the person has a sprain strain injury, however, the patient is complaining of radiculopathy down the leg. It is possible that they have a sprain strain injury, but that's probably not sufficient to cause the radiculopathy. So we need to make sure then that our diagnosis actually matches the pain pattern that the patient has. The next question then is, does the pain pattern match the radiographs? So remember what we said. In the absence of symptomology, in the absence of pain, oftentimes we try to leave the things alone. So if a person says that my pain is down at L5 on the left-hand side and it's running into the front of the upper thigh, and then you go and you look at you go through the orthopedic exam and it seems like they have a disc problem, but then you look at the MRI, and the MRI says that, well, this patient has a disc herniation on the left side at L5, then we know that there's a problem, because their pain was on the right side anterior thigh, but the disc herniation is L5 on the left side. So if it is a disc herniation with a compression or irritation of the nerve root, then we would actually expect that the discomfort would be on the left side, but that there would be actual nerve irritation then that would go along the lower leg, not the anterior front thigh. So knowing the things such as the dermatomes become extremely important, especially when we're trying to figure out, does the radiograph match their pain pattern? The next question then is, does the pain pattern match the orthopedic exam? So again, if we are looking and we're suspecting that a patient has a severe sprain of the hip joint, then we would go in and do something like Patrick Faber test. If there's pathology into the hip, then yes, that is a positive indicator then through the orthopedic exam that there is some sort of hip joint pathology. Of course, one test is not sufficient. We need to go through the others and start to target primarily, is this an SI? Is this a true hip? In which case we can look at doing things like scouring tests and other orthopedic tests to help us nail down the diagnosis. Finally, the final things we need to really keep an eye on then is that really overall in everything that we're doing, we're not only looking for a complete diagnosis, we're looking for possible complications. Remember, I started off this webinar saying that each patient is allowed to have more than one problem, and that really is true. So as we go through the history, through the orthopedic test, through the radiographs, we're doing two things. One is we're looking for the source of the problem that the patient has and the diagnosis for it. But the other thing that's also very, very important is we're looking for any other possible complications. So this is when, say, a patient comes in with lower back problems, you suspect that they have radiculopathy that's running down the leg, you go through and you do your orthopedic test, things like straight leg raise cause problems. You're suspecting then that yes, they have a disc herniation, that there might be a problem. You look at the radiographs. Radiographs show us that yes, there is a disc herniation at the level that we suspect it to be. However, we also find on the radiograph then that this patient has an active tumor. When we see that active tumor, that brings us back to the contraindications. That active tumor overrides any type of treatment that we would do until that tumor is taken care of. So it's important that if we had just ignored what possible complications were there, we would have tried to help this patient, but in the end we could have caused them more problems. So it's important then that as we make our diagnosis, we catch these problems. The next thing then that we think about is this a patient that we can help? Obviously, we want to be the best help to any patient we see. And so as we go through the process of doing the history, the evaluation with the orthopedic tests and the radiographic review, we want to say in the end that yes, this is a patient that this program can help, that it was designed for, that can actually help them with the discomfort that they're feeling. And as a result then, by the end of this, if we can say after going through all that review that this is a patient we can help, then we actually know we have a good solid plan of attack. Having that plan of attack then will let us know what we're going to do first, how we're going to do it, and what we would expect along the way as we go through treating this patient. Hopefully, throughout this process of the webinar, you have gotten a better understanding as to the process that we would go through when it comes to figuring out what is wrong with the patient, where the problems are, and how we can help that patient. Remember, the bottom line with the evaluation then is that after the entire process with the review of x-rays, with the orthopedic tests, with the complete history, we can actually say in the end, yes, I can help this patient, and this is how we are going to help this patient. If you have any questions for any of the stuff that we've gone through or for more specific details, please make sure you go back and refer to the manual that you have, particularly the section on patient evaluation. Our next webinar will go through some of the other steps then for essentially level 1 of the PneuBack program. Thank you for your time, and we will look forward to seeing you on future webinars.